The topic for this project is cognitive behavioral therapy for patients with coexisting chronic pain and opioid use disorder. Approximately 40% of patients questioned with opioid use disorder had chronic pain prior to the opioid use disorder diagnosis. If the chronic pain is left untreated, it persists, often leading to opioid use relapse following opioid detoxification. This project will focus on patients with opioid use disorder that have coexisting chronic non-cancer pain. The goal of this project is to determine whether implementing cognitive behavioral therapy in conjunction with medication-assisted therapy already being provided for the chronic pain and opioid use disorder will have an impact on the success of the patient to maintain sobriety following discharge from inpatient detoxification. So chronic pain often leaves patients unable to complete activities of daily living, activities they had previously enjoyed, and overall is just a lower quality of life. Ineffective management of the chronic pain often leads to misuse of opioids. This is because patients will self-medicate with higher doses of the prescribed opioid in an effort to get a handle on their pain. Opioid use disorder causes intense cravings that lead patients to prioritize opioid use over other responsibilities such as family, personal finances, work, school, etc., and leaves these folks unable to function in normal society. So cognitive behavioral therapy is an evidence-based intervention that modifies beliefs in maladaptive behaviors. The patient first learns to recognize their behaviors as maladaptive, and then learns to implement new adaptive behaviors that take place of the old. So benefits of CBT for opioid use disorder. Patients learn to recognize situations that they're likely to result in relapse, and learn new coping mechanisms to help them deal with those situations. It encourages engagement with the adherence and treatment plan, including pharmacotherapy. It also treats underlying psychiatric disorders that either complicate or act as a trigger for substance use. So the benefits of CBT for chronic pain, mainly it focuses on improving the pain coping skills. So stuff like active pacing, distraction, pleasant activity scheduling, that type of stuff, and focuses then on altering behavioral responses to the pain. So using the new coping mechanisms to abstain from maladaptive behaviors like opioid use. So components of this therapy include psychoeducation. That's recognizing the relationship between one's thoughts and feelings and their chronic pain, and challenges them to restructure those thought patterns. Acceptance and commitment therapy is another form of CBT that emphasizes observing and accepting the thoughts and feelings as opposed to challenging them like ordinary CBT would. So part of the clinical guideline for opioid use disorder treatment is that psychosocial therapy combined with pharmacological therapy improves outcomes significantly and should be used as a part of a comprehensive treatment plan for those with opioid use disorder. They've known for quite some time that that medication-assisted therapy alone just isn't enough. You need something adjunct to that in order to be effective. So clinical guidelines for chronic pain treatment also include psychosocial therapy, along with other non-pharmacologic interventions, and should be used in conjunction with non-opioid analgesics to treat those patients who have chronic pain. So part of the assessment when you're dealing with folks that are in opiate withdrawal is to use this scale. It's a clinical opiate withdrawal scale. It uses a point system that allows the provider to accurately time the first dose of Suboxone or Subutex or whatever drug they choose to use, so that the patient doesn't go into a precipitated withdrawal. So withdrawal symptoms such as GI distress, yawning, sweating, runny nose, etc., are all assigned points. And when the score reaches a level predetermined by the provider, they can then start the medication-assisted therapy. If it starts too early, if you start the patient on these meds too early, they'll go into what's called a precipitated withdrawal, and that's an immediate onset of severe opioid withdrawal symptoms. This happens because there's still a significant level of opioids from their last use still in the system, and the body does not like that and throws them into immediate awful withdrawal. The symptoms are magnified quite a bit and are quite uncontrollable. So another assessment that we plan to use is a pain assessment, and we're just going to use a visual analog scale. The patient is shown a 100 millimeter line. The left end of that scale equals no pain. The right end of the scale equals the worst imaginable pain. The patient is asked to point to the area on the scale that best indicates their level of pain. The provider then uses that data to determine a baseline level of pain or to determine whether the chosen intervention is working. For patients with chronic pain, this assessment is performed with every encounter. So the PICO question for this project is, in patients who have chronic non-cancer pain and misuse opioids, does cognitive behavioral therapy compared to no cognitive behavioral therapy in conjunction with pharmacological treatment result in fewer opioid misuse relapses after 1 month, 3 months, and 6 months? So in the current literature, shows that long-term use of opioids likely puts a patient with chronic pain at risk of developing opioid use disorder. Again, this is because these folks will develop some sort of tolerance to the prescribed opioid, and then in an effort to get to get a handle on their pain, they will just increase that dose themselves, self-medicating. And then it just kind of snowballs from there to using illicit drugs. So efforts to reduce overdose on opioids are becoming a serious public health concern. This is due to the recent increase in overdose deaths and ease of access to drugs like fentanyl on the black market. The CDC has established new guidelines for management of chronic pain that leave out the use of opioids in an effort to prevent addiction. Cognitive behavioral therapy combined with pharmacological interventions is shown to be more effective than pharmacological interventions alone. In one study, the addiction severity index scores decreased from the experimental group, so that's the cognitive behavioral therapy and medication-assisted therapy. The perceived stress scale scores decreased for the experimental group. And the number of positive opioid urine screens decreased for the experimental group, indicating fewer relapses. So the literature also shows that chronic pain plays a huge role in why people misuse opioids. One study with 203 participants reported that 47% of those surveyed experienced persistent chronic pain. Those same patients also reported that their addiction to illicit fentanyl products started with misusing prescribed opioids like Percocet or Norco or Vicodin. And illicit fentanyl products have been found in the blood of over 50% of autopsies involving opioid overdose deaths in many jurisdictions throughout the country. Literature also shows that the presence of chronic pain negatively influences response to opioid use disorder treatment. So chronic pain often results in physical disability, leading to a decrease in psychosocial function and quality of life aspects needed for successful treatment of opioid use disorder. So these folks need to be able to do things like find a job, attend outpatient appointments, attend NA meetings, etc. And the chronic pain, if it's not addressed, just does not allow them to do that. And cognitive behavioral therapy is an effective method for dealing with chronic pain. Literature recommends that treatment for both chronic pain and opioid use disorder include medication management alongside psychosocial interventions like CBT. So there is a little bit of confusion in the literature. There are lots of inconsistent definitions that I found while searching the literature. A lot of these terms like dependence, substance use disorder, misuse, addiction, abuse, etc., are all being used kind of interchangeably, but they're all kind of they all have different definitions, but they seem to be used interchangeably in the literature. And there's also conflicting research on this population in regard to prevalence, risk factors, and clinical management approaches. This population is difficult to kind of put a thumb on. They're hard to track sometimes, so it makes a researcher's job pretty difficult, and that's why I feel like there's some confusion in the literature about these things. I think if they cleared some of these definitions up and had a better way to track, to track these folks, I think there'd be a lot less confusion. So for this intervention, there has been successful implementation. This involves 12 30 to 45-minute sessions designed specifically for dealing with coexisting chronic pain and opioid misuse. It was implemented along with the facility's normal medication-assisted treatment for opioid use disorder. The first session was an informal meet and greet that took place in an inpatient detox facility. And in this meet and greet, the provider basically got an overview of the situation. So they got an assessment of their substance abuse, their pain, the patient's perception of opioid use, and an overview of the treatment program in general. Sessions 2 through 11 were structured into 3 10 to 15-minute sections. And these all took place in an outpatient setting once the patient was discharged from the inpatient detox center. So the first section of these sessions was just a check-in, and kind of setting an agenda for the current week. They went over medication adherence, substance use, pain and coping, and the previous week's homework assignments. In the second section of these sessions, they focused on acquiring new coping skills, and then the last part of the sessions were focused on answering questions related to the new coping skills and assignment of the homework for the next week. During these sessions, urine samples were also collected so that they could verify that the patient was staying abstinent from opioid use. Once they got through 2 through 11, session 12 involved a review of the new coping skills learned in 2 through 11, and they put together an all-purpose coping plan. So just kind of tying things up. So outcomes from the implementation. It included higher rates of opioid use abstinence from baseline as evidenced by fewer positive UTOX screens, clinically significant reduction in pain from baseline, and a higher rate of participant satisfaction with the treatment plan. The theoretical framework used to guide my project is going to be Orm's self-care deficit theory of nursing. This framework was picked to guide the project because of its emphasis on identifying self-care deficits, teaching the patient how to deal with those deficits, and having the patients deal with those deficits on their own. This theory works well with the chosen intervention because cognitive behavioral therapy aims to achieve those same goals. So here's a look at the concept map. Let's start with the patient up at the top. The patient has both chronic pain and opioid use disorder. See a line moving down to the provider. During the provider's assessment, they will perform both a pain assessment and a COWS assessment. And from there, they will adjust medications as needed until the detoxification process is done. And from there, another provider will start the CBT, so the green box in the middle there. In session 1 of the CBT will happen prior to the patient's discharge from inpatient detox. Sessions 2 through 11 will continue following discharge from the inpatient setting, and that'll be in an outpatient setting. And in those sessions, again, they'll be learning coping mechanisms for the opioid use disorder and coping mechanisms for chronic pain, and hopefully modifying the maladaptive behaviors they've picked up along the way. So Orm's theory ties into this when we initially identify the self-care deficits. So for instance, sufficient intake of air, food, water, and adhering to social norms. Once those self-care deficits are identified, cognitive behavioral therapy teaches the patient to fulfill those deficits on their own. So implications. CBT and MAT for chronic pain and opioid use disorder have the potential to reduce the number of opioid use relapses and decrease the level of pain for this population. Essentially, this allows the patient to participate in society and provides a greater quality of life. As far as future plans are concerned, I've spoken with and presented evidence to the attending psychiatrist that oversees the Inpatient Recovery Services Unit at UTMC, and he has agreed to meet and further discuss plans to have session 1 start in the inpatient unit prior to discharge, and then sessions 2 through 12 to continue in UTMC's outpatient recovery services. So again, start to finish, in the inpatient setting, we're going to begin medication-assisted therapy, get the withdrawal symptoms under control. Once the withdrawal symptoms are under control, we can start session 1 of CBT, and after that, the patient can discharge from the inpatient unit. In the outpatient setting, they're going to maintain the medication-assisted therapy and make medication changes as needed, and also continue with sessions 2 through 12 of CBT. And there are the references.